Hi, Adult Health One. So this is Module 7A. There's going to be two parts to this one too. This is a bunch of renal, urinary disorders, and then this PowerPoint is going to have sexually transmitted infections as well. 7B is going to have female and male reproductive disorders. There were just a lot of different disorders, so I decided to break them up. Each PowerPoint should probably only be about an hour though, so it's not too crazy, thankfully. Here are our objectives. And all right, so assessment, we're going to start with assessment of renal and urinary function. So a lot of this stuff may be review from funds, I'm guessing. Renal system, it's composed of two kidneys. Urinary system is composed of the two ureters, the urinary bladder, and then the urethra. So the two systems work together to help maintain homeostasis in the body. For example, urine is formed as blood is filtered through the kidneys. The bladder then provides storage, and the ureters and urethra act as passages for urine to exit the body, completing the function of excreting waste from the body. So things are working together, right, to get toxins and waste and whatnot out of the body. Kidneys perform the following functions essential to maintenance of homeostasis. The kidneys work on excretion of waste, regulation of fluid and electrolyte balance, regulation of acid-base balance, regulation of blood pressure, secretion of erythropoietin for red blood cell production, and activation of vitamin D. So the urinary system provides for the storage and passage of urine, promoting continence and facilitating voiding. The nephron is the functional unit of the kidney. You don't have to memorize this, but there's approximately 800,000 to 1.2 million nephrons in each kidney. So that's times 2. I just threw that number out there because it's pretty impressive. Each nephron, this goes into all the things that are part of a nephron, and then a glomerulus is a collection of semi-permeable capillaries responsible for filtering blood. So we care about the glomerulus simply because when we start talking kidneys, we talk about the glomerular filtration rate. All right, so just know that the glomerulus, they're semi-permeable capillaries, and they're responsible for filtering blood. The rest of the notes in here are all about the different little pieces and parts of the kidneys, okay, which be aware of, but at least for us at this point, we don't have to memorize. You probably already memorized them for funds and maybe even patho, right? Kidneys receive 20 to 25% of total cardiac output, which is a flow rate of approximately 1,200 mils of blood per minute. The renal artery is a branch of the abdominal aorta, okay? These are our geriatric considerations. So don't forget, we always consider what stuff looks like in our older people. So our kidneys decrease in size, number of nephrons decrease. So not only do kidneys decrease in size, but all the functional parts of them, it's because the functional parts are decreasing as well, right? So blood flow to kidneys decrease, our GFR, which is our glomerular filtration rate, decreases. We may see an increase in BUN and creatinine. You have all these physiological changes. The bladder capacity decreases, so our people have urinary frequency, urgency, and possibly incontinence. And then for guys, we have that enlargement of the prostate gland, which leads to urinary dysfunction. Urine formation. Urine is formed through the continuous processes of filtration, reabsorption, secretion, and concentration. The amount of blood filtered by the glomeruli in a set amount of time is the GFR. So the GFR is how much blood is passing through them in a set amount of time. Okay, it's approximately, should be around 125 mils per minute. This rate of filtration results in an average of 180 liters of filtrate per day. Per day. Isn't that crazy? Although a large volume of filtrate is produced, the reabsorption that occurs beyond the glomerulus returns much of this volume to the body. So a lot of that just goes back into filtration or into function, right? And a healthy adult, approximately 1 to 3 liters of filtrate is actually excreted as urine each day. Regulatory mechanisms enable the kidneys to maintain a constant GFR despite global changes in blood pressure. This is a powerful compensatory mechanism, but it cannot typically compensate for systolic blood pressures below 70. Pressures at or below that level result in a decreased GFR. So what this is saying is, even though we may have fluctuations in blood pressure, until we hit that systolic of less than 70, which is bad news, the GFR is able to maintain that filtration rate, okay? Even if your systolic gets scary low. So the kidneys, it's a compensatory mechanism for them to be able to keep functioning even when other things are going wrong. All right. Tubular reabsorption is the second phase of urine production. It is the movement of water and solutes from the tubular filtrate back into the blood. All right, so it separates things out, returns what it can back to the blood. So that helps keep our volume levels in like a homeostatic state, okay? So then we have antidiuretic hormone and aldosterone. They control the permeability of the DCT tubular secretion. That is the third phase of urine formation. Substances move from capillaries into the renal tubule cells and then into the urine to be excreted. Following tubular secretion, urine must be concentrated before its excretion from the body. Without the kidney's ability to concentrate the urine, the body would quickly experience dehydration due to significantly large volume losses. The loop of Henle plays a significant role in this final step of urine formation. The descending portion of the loop is permeable to water and is responsible for reabsorbing the additional water required to concentrate the urine. When we start talking about diuretics, we need to think about certain parts of the kidney and what part of the kidney the diuretic works on, right? And what that part of the kidney does. And so how is the diuretic affecting that normal function of the kidney? All right, so water balance. Water accounts for approximately 50 to 60% of the body. 2/3 of this water is found in intracellular fluid, and the majority is found outside the cells in the extracellular fluid. Remember, that's the interstitial space and plasma. Water found in the ECF is distributed throughout the plasma, lymph, and interstitial fluids. Small quantities of water are found in the CSF, GI, respiratory, and vitreous humor of the eye. The kidneys are the primary organs responsible for maintaining water balance within the body. For this fluid balance to be maintained, the kidneys must ensure that the volume of water taken into the body is equal to the volume of water lost from the body. Water is taken into the body through consumed liquids and foods. Water is also present in the body as a byproduct of metabolism. Water losses occur through perspiration, urination, defecation, cutaneous transpiration. This is water loss just through the skin, and exhalation. Kidneys are able to prevent dehydration when fluid intake is low and prevent volume overload when fluid intake is excessive. The role of the kidneys in maintaining water balance is invaluable. When the kidneys lose regulatory capacity, homeostasis is altered, and all body systems are affected. Complete complete loss of this regulatory function can result in death. This slide 7, is straight from your book. It talks about the process of dehydration and how the different hormones and receptors are stimulated into causing the body to respond, right? Whether it holds onto fluid, releases fluid, whatever. So slide 7, take a look at this. All right, electrolyte balance. The kidneys also control the composition of the blood by reabsorbing and secreting electrolytes to maintain levels within normal ranges. The PCT is responsible for reabsorbing up to 80% of the electrolytes contained in the filtrate. If you look at 61.7, illustrates the locations throughout the tubules at which various solutes, including electrolytes, are reabsorbed and secreted. So different things are reabsorbed and secreted at different parts of the kidneys, okay? So again, if we have damage to certain parts of the kidneys and not others, or we're on certain medications, like diuretics can affect the kidneys and the functioning of the kidneys. So that's why all of this matters, okay? So rate of reabsorption and secretion of each electrolyte is dependent on the concentration of that electrolyte in the serum. When a higher than normal electrolyte is detected, the kidneys act by increasing the secretion of this electrolyte. Likewise, when a specific electrolyte level is lower than normal, the kidneys increase the reabsorption of that electrolyte to restore homeostasis. As an example, the release of the hormone aldosterone from the adrenal cortex is stimulated when serum levels of sodium are decreased, causing increased reabsorption of sodium in the distal tubule. As a result, sodium is reabsorbed, increasing serum sodium levels. Water is also reabsorbed. Then we are talking, the kidneys also play a role in maintaining the pH, right? pH less than 7.35 is acidotic, and greater than 7.45 is more alkalotic, which is more basic, right? There's three mechanisms that work to maintain normal serum pH. So like we talked about, we have an acid-base buffer system, we have the respiratory system, and then of course the renal system. Although the renal regulation of pH is the last mechanism to activate, remember that whole bicarb thing? When the serum pH is altered, its response exerts the most control in restoring the pH to a normal level. The kidneys are the only organs with the capability to fully excrete hydrogen ions from the body. So remember, hydrogen ions are acidic. So if we are needing to get rid of hydrogen, we're dependent on our kidneys to do that. Kidneys also produce hormones, okay? So some of these hormones include renin, erythropoietin, activated vitamin D. Like we couldn't do anything with vitamin D if it wasn't activated. Bradykinin and prostaglandins. So renin just aids in blood pressure regulation. Erythropoietin is produced exclusively by the kidneys, and that is produced when we have decreased renal blood flow and hypoxia. So erythropoietin stimulates the bone marrow to produce RBCs. Okay, what's interesting is you can actually administer erythropoietin to get the bone marrow to make some more RBCs. Okay, vitamin D. Although obtained through diet and exposure to UV radiation, vitamin D must be activated in order to be useful to the body. The activated form of vitamin D is required for calcium to be absorbed in the GI tract. A patient with renal impairment can have deficiencies in activated vitamin D and as a result decrease serum calcium levels. Because of the inverse relationship of calcium and phosphate, excuse me, I just drank a Monster and now I'm all burpy. Serum phosphate is typically increased in patients with renal impairment. Prostaglandins are hormones produced by various tissues of the body. They typically affect the tissues surrounding their site of production, okay? The kidneys specifically produce prostaglandin E2 and prostacylin. These PGs function within the kidneys to trigger vasodilation, resulting in increased blood flow to the kidneys and increased sodium and water excretion. Prostaglandins synthesized in the kidneys may also play a role in lowering systemic blood pressure as a result of decreasing vascular resistance. As the quantity of functional kidney tissue decreases in renal failure, the production of PGs also decreases. The absence of the vasodilating effects of PGs may be a contributing factor to the development of hypertension often associated with renal failure. Bradykinin, I don't know that I'm saying that correctly, is a hormone released by the kidneys in response to the presence of PGs, ADH, and angiotensin II. It increases the permeability of the capillary membrane to certain solutes and dilates the afferent arteriole to ensure adequate reabsorption of solutes and blood flow to the kidneys. So we have all these hormones that go into working in the kidneys, and a lot of it is that cascade effect, you know. Remember, the angiotensin 1 goes down to the lungs and makes angiotensin 2, and you know, with the RAS system and all that, everything's a cascade. So same with these types of hormones, it's all a cascade. Patient history assessment considerations. So because of the variations in the anatomy of the male and female urinary system, each sex is predisposed to unique complications that should be considered and assessed. Females, for instance, are more susceptible to developing UTIs than males, you know, because the females have like that shorter little urethra. And then the prostate gland in the males, that's its own complication, right? BPH, prostatitis, non-malignant enlargement, and potential prostate cancer. So changes in the urinary system and its function occur with increasing age, which we've talked about. It also increases risk of developing like bladder cancer and other cancers related to the reproductive organs. So race is also a consideration when we are talking renal health, because evidence has revealed an increased incidence of hypertension and diabetes mellitus in the Black population. According to the National Kidney Foundation, 1 out of 3 Black adults over the age of 65 is affected by hypertension, and more than 3 million Black adults have diabetes. Both hypertension and diabetes are precursors to the development of renal dysfunction. So we would call those comorbidities, right? And the older Black population is at greater risk for these comorbidities that we know are often seen related to kidney dysfunction because they work on the vasodilation and changes in how everything is processed. So we also want to talk to people about occupational history. You know, that's like exposure to chemicals and whatnot, chemicals and carcinogens. Even diet can play a role. If somebody who consumes a lot of salty foods, that can increase their risk for renal calculi. And then smoking is the #1 risk factor for bladder cancer. So all of that. There's different meds that can be used related to bladder cancer and bladder dysfunction. Some of them, like pyridium, actually turns your pee orange. So although we're not necessarily having to teach about the med itself, you are going to want to give people a heads up that it can turn the pee orange, because that is alarming, to say the least, if you're not expecting that. Also, don't forget, when we are looking at meds that patients are taking, a lot of them can be nephrotoxic, right? So we're going to want to look through what they normally have and see if there's anything on there that could be contributing to their renal dysfunction. Here's a list, slide 11, of antibiotics, analgesics, and some other meds and different substances that can contribute to renal dysfunction. Renal vocabulary related to assessment. So this is just some things to know, like pattern of urination. That includes frequency, flow, amount, all of that stuff. Nocturia, which is having to pee at night. We think about that with our older population because they may be having difficulty emptying their bladder completely, right? And then they're up and down at night. They could be having BPH issues, all of that. And then we get into fall risks. Dysuria, anuria. Anuria is total urine output of less than 100 mils in 24 hours, okay? Then we have oliguria, and we want to think about, can people control the flow of their urine? Are they having problems related to that? Hesitancy, urgency, anything like that, any incontinence. Physical exam related to urinary function. So first we're going to look at skin, mucosa, abdomen, extremities, because renal impairment can have an effect on all the other body systems. And then we're going to go to looking at actual, like the urethral meatus, right? That may be necessary, just to make sure that there's no outward physical manifestations of anything that may be contributing to urinary function. You could have masses, you could have, if their skin is excoriated, it may be painful to urinate, anything like that. So anything on the outside that we can see. We're going to auscultate. We're going to listen for a bruit over the abdominal aorta, and then we're going to listen to the renal arteries. We're going to palpate the 4 abdominal quadrants and the bladder. The bladder's typically not palpable, but if your person maybe has to urinate and the bladder's distended, sometimes you can feel that in there. Percussion, we're going to percuss over the symphysis pubis down towards up towards, I should say, the umbilicus. Blood tests related to urinary function. So this is like your serum creatinine. Creatinine is filtered by kidneys and excreted in urine. Renal dysfunction is the only cause of increased serum creatinine. Okay, so if our serum creatinine is off, we know there's something up with the kidneys. Increased serum creatinine does not occur until at least 50% of kidney function has been lost. We're going to look at urea. Urea is what gives urine that ammonia smell. It's a byproduct of protein metabolism in the liver. We're going to look at our BUN, which is our blood urea nitrogen. This increase can occur with renal dysfunction and liver disease. And then the BUN to creatinine ratio is usually 10:1 to 20:1. When ratio is within normal limits, but both levels are elevated, then renal dysfunction is likely. All right, so we always look at BUN related to creatinine. And this, we always think of that ratio. Uric acid levels are dependent on kidney function. Bicarb, those are part of ABGs, the bicarb, remember, which we talked about. And then, of course, our electrolytes. If our electrolytes are out of balance, that definitely can be reflective of kidney malfunction. Urine test, bedside urine dipstick test. We use a fresh sample. Okay, that's bedside. They do a little sample, you dip the test. It can give you the presence of protein, glucose, bilirubin, blood, ketones. It can give you the pH, right? And that's all bedside, done and done. Urine analysis should be from the first void of the day. You need to send it to the lab within an hour. If you can't get it to the lab in an hour, it's okay to refrigerate, but that's not the ideal situation, all right? And don't just put it in the staff lounge refrigerator, because nobody wants somebody's urine next to their lunch, all right? Culture and sensitivity, We do that when we are looking for infection. A lot of the times you'll see a urine analysis written for urinalysis with CNS if indicated. So they'll run the urine analysis, and then like if WBCs are up, or they see like blood in the urine or something, then they will run the culture and sensitivity. If the urine analysis does not indicate a need for CNS, then they won't run it. A composite urine collection. So this is like our 24-hour urine collection, all right? So in real life, a composite urine collection can range from 2 to 24 hours. So mostly, I mean, I've never seen it done not 24 hours, but who knows, right? So the biggest thing is to remember is that we throw out the first urine of the day. We keep the entire urine collection on ice, or potentially refrigerated, again, not in the staff lounge. And then the final urine before that 24 hours is up is added to that catch, all right? And then we send the whole thing to the lab. We also may look at creatinine clearance. This is a reliable indicator of GFR. Urine's collected for 24 hours again. Could be shorter, but usually 24. And then we compare the creatinine in the urine to the serum creatinine, okay, and see what's going on with that. This is box 6.1. This is related to doing a clean catch urine sample, box 61.1, sorry. So if you are unsure about the steps of getting a clean catch urine sample, definitely check this out. Renal imaging. So you can have an ultrasound, an x-ray, a CT, an MRI. When we do an x-ray, we call it a KUB. That's kidney, ureters, bladder. A lot of times when we had feeding tubes, or any sort of tube that's going into the stomach area, we would get a KUB on it to verify placement. You also can have intravenous urography or IV pylography. These use contrast, all right? Also, your person has to be NPO 8 hours before the procedure. Study lasts for 30 to 45 minutes, so it's not crazy. A lot of the education that we do when we use contrast, is because contrast can make people feel like they're flushing. I have also heard that contrast can make patients feel like they're urinating. Another weirdo thing is a salty taste in the mouth. So as long as we alert patients to this beforehand, good to go. But imagine you're in this study that's going to last 30 to 45 minutes and you feel like you're peeing your pants. That would be horrible. So we need to just keep these educational things in mind. They do with the urography and the IV pylography, they get a serum creatinine before the procedure, and then they compare it after, because we do a serum creatinine before because contrast itself can be nephrotoxic. So we want to make sure that afterwards we haven't seen any negative effects related to that contrast. So post-procedure, we're going to monitor for reactions to contrast, changes in urinary output, and we're going to want to increase fluid intake to help flush that contrast out. The faster we can get that contrast out, the better. This is slide 18. It is a safety alert. Safety alert, nursing considerations for patients receiving IV contrast. So this is all the things we need to think about. Obviously, there's consent. We need history of allergies. And remember, we don't just say, are you allergic to contrast? We ask about iodine and shellfish, all right? We confirm the presence of emergency medication and equipment at the bedside potentially. We get that baseline serum creatinine. We review the patient history, educate the patient regarding the contrast, what they may feel. ensure patency of our IV. We don't want to send our patient to IR to get contrast if our IV is not working. We want to be constantly monitoring our person for allergic signs to the contrast. That can be rash, dyspnea, tachycardia, and then afterwards, and even before, honestly, we want to educate our person that they're going to need to increase their fluid intake following the study. And then afterwards, we verify that they have increased their fluid intake, okay? This is coordinating care for patients with urinary disorders now. Urinary tract infections. So the big thing with urinary tract infections is people who end up with UTIs that are hospital related. You're in the hospital longer, you're on antibiotics that you potentially did not need before. It can go systemic on you and it ends up with a longer hospital stay. So risk factors, we talked about UTIs occurring in females more often because of the shorter urethra. Older males, however, can have more frequent UTIs because of the BPH and potential for urine retention. So signs and symptoms: bladder irritability or dysuria, which is painful urination, urinary frequency, urgency, urinating in small volumes, like you feel like you have to really, really, really go, but then you only have a little bit of pee, right? Gross hematuria. When we say the word gross, as far as medical terminology, it means I can see it with my eyes. So hematuria, blood in the urine that I can see with my own eyes. I don't need to send it off to the lab to discern whether or not there is blood present. Microhematuria, that is going to require it being looked at in the lab, okay? People can have suprapubic pain, systemic symptoms, right? I could have fever, nausea, vomiting, flank pain. Infection has potentially migrated to the kidneys. When a UTI migrates to the kidneys, we refer to that as pyelonephritis, and that is considered a step up in seriousness of infection, okay? Diagnosis is going to be made on clinical manifestation and then urine analysis with culture and sensitivity. Our treatment: antibiotics. Now, get this, if it is uncomplicated, which means it's just a UTI, 3 days of antibiotics is the recommendation. Now, if it's complicated, if it has traveled, then there's a 7-day course. And we can also do bladder analgesics. Bladder analgesics work on the smooth muscle of the bladder and basically calm it down. Like, people can get almost spasms when the bladder is irritated. So bladder analgesics can calm that sensation down. RN considerations related to UTIs. So first of all, we're going to assess for signs and symptoms of infection. We're going to assess for that flank pain. We're going to assess for any urinary symptoms. Actions: antibiotics as ordered, analgesics as ordered. Maybe we need to get that clean catch urinalysis. Education is going to be, first of all, we're going to have them increase fluids, right? And then we are going to teach them signs and symptoms of worsening infection, because the problem with the UTI is it can always travel to the kidneys, and that is a bigger deal. So we're going to teach them about that. And then we're going to teach them about UTI prevention in the first place. And then likely we have some med education. Urolithiasis. There we go. Urolithiasis. These kidney stones, okay? Urolithiasis, kidney stones. These can actually occur in the kidneys, ureter, and bladder. Risk factors: male, white, family history, gout, type 2 diabetes, malabsorption conditions such as Crohn's, and dietary habits such as high sodium. Signs and symptoms: pain, crazy pain. They're going to get nausea, vomiting, flank pain, gross hematuria. Again, that means I can see that blood in the urine just with my eyes. We're going to use a CT to diagnose. Treatment: 60% of kidney stones actually pass on their own. All right. So a lot of times you're going to be sent home with what looks like a little filter, and you're going to filter your urine to wait for that stone to pass. They'll give you pain meds, they will give you things to calm the bladder, but really 60% of this is waiting for that stone to pass. Surgical intervention is possible if you're peeing and filtering your urine and do not see a stone within 4 to 6 weeks. So we will call that trial passage, or not we will call it, it is called trial passage. So slide 23. If a trial of passage is prescribed, it is imperative that the patient either confirms passage of the stone with actual stone fragments collected while straining urine, or that a KUB or CT confirms passage of the stone. A retained asymptomatic ureteral stone can insidiously obstruct the flow of urine, resulting in potential loss of kidney function. So what this is saying is that if we send you home and we're like, you need to strain your urine, we need to see that stone. That is what that means. We need to see that stone. If not, we're going to verify with KUB or CT that the stone no longer exists. And the reason is, let's say your signs and symptoms kind of subside, and maybe you just assume that that means that that stone has passed. It doesn't necessarily mean that. And the problem is, out of nowhere, that stone can decide to move and can obstruct the flow of urine. And then you end up with a whole bunch of emergent problems, okay? And at that point, you very well could be looking at a surgical intervention when surgical intervention was probably not needed in the first place. Could have been avoided, basically. Here are our RN considerations. So our assessment: what's your pain? A lot of times this is 10 out of 10. If you look at renal stones under the microscope, like the uric acid accumulations related to gout, these kidney stones are spiked. They are just spiked all over the place. So they cause crazy pain. People are going to have nausea and vomiting. We're going to do a urine culture. We're going to run some labs, see what's up. Actions: probably opioids. Like, this is 10 out of 10 pain for people. So don't forget, anytime we prescribe opioids or have patients on opioids, we're going to do education related to opioids. Adverse or expected side effect of opioids is constipation. So we're going to want to talk about bowel care interventions related to that. We're going to give our person some antiemetics, send them home with some Zofran. We're going to encourage fluids because that's going to help with urinating, which is hopefully going to increase the time frame in which that stone is passed. And then we're going to teach them how to strain that urine, and that we need to see that stone. We need to see it. And then, so education related to straining the urine, and then kidney stone prevention, right? That could be diet, that's increasing fluids, all of that stuff. Urinary incontinence. So urinary incontinence is defined as the involuntary or uncontrolled loss of urine in any amount. Types of incontinence include stress incontinence, urge incontinence. It can be a combination of both. Overflow, reflux, and functional incontinence. Be familiar with those. Diagnosis: we start with a thorough history. We're going to ask medical, urological, voiding, neuro, reproductive history, We're going to talk about patterns of incontinence and voiding characteristics. Is the stream the same as it's always been, or is it less? Believe it or not, a voiding diary may provide useful information. So if somebody's having problems with incontinence or urination in general, keep a diary. What did you eat and drink beforehand? How many times did you have to get up during the night? Was it difficult to urinate? Was the stream lesser than it usually is? All of that stuff. Did you have, with urgency, that's that feeling of like, oh my gosh, I gotta pee right now, right? So did you have feelings of urgency, frequency? Is there hesitancy? All of that stuff. Lab testing, urine culture, maybe with CNS, blood test, BUN, creatinine, that sort of thing. Imaging, maybe, KUB, IV pyelogram. We may use contrast, like we've been talking about. There's lots of diagnostics that they can do. Primary goal of treatment, when possible, is to prevent or stop urinary leakage, right? Because that really can have the biggest effect on somebody's ADLs. If you're leaking urine, you maybe don't want to go out at night. You may be embarrassed. There's a lot of psychosocial aspects related to incontinence that can affect people's daily living. We're also going to want to talk about skin care, odor control, all of that sort of stuff. Prevention or reduction of damage to the upper tracts or the kidneys because of renal function. So we're going to want to make sure that those kidneys are okay, that there's nothing wrong that requires further intervention. Also, there's meds that you can take for incontinence. There's also non-pharm, like Kegel exercises. There's bladder slings. There's a pessary, which is a device that fits into the vagina to support the bladder. It kind of goes like up and in. Usually ladies who have had babies, especially multiple babies, that bladder, everything starts to sag, because everything's been stretched out. So when we stretch things out, eventually that elasticity does not go back to what it should. So you can end up with the bladder protruding down through the urethra. So they use a pessary. It just kind of goes up in the vagina. It goes in the vagina and actually helps push the bladder back up. So I should say the bladder comes through the vagina. I think I said urethra, sorry. But anyway, there's pharm and non-pharm options for this. And then surgical, that is when they go in, they can put a mesh up in there, a suburethral sling. That's for stress incontinence. Complications related to urinary incontinence, again, the skin. We're worried about that skin. When that area is macerated, and then we have, even if they're not incontinent of bowel, but that area down there, the skin is broken, then we worry about infection because of the close proximity of E. coli, right, related to bowel movements. It's also painful if you have any macerated skin is painful, but imagine you're peeing and urine can be acidic. I mean, that can burn, rubbing of fabrics on there can be really painful. So you just have to work on having open conversations. And again, the psychosocial aspect, there can be a lot of depression, lack of social interaction, all of that stuff related to this. And keep in mind, this may not be just your older people. This can be younger people, especially women who have had multiple kids. Incontinence, not uncommon. This is table 63.1, slide 26. This is types of incontinence. I want you to focus on stress incontinence, urge incontinence. Let's see. What else? Now this one is meds. These are meds related. This is slide 27. So meds related to incontinence. Look at your anticholinergics. All right. Look at your estrogen derivatives and your beta 2s. Okay. Be familiar with those. So safety alert, incontinence can be related to an increased fall risk, especially in older patients. Nurses caring for incontinent patients can decrease fall risk related to incontinence by regular bedside rounding, establishing a voiding schedule, and by offering voiding when they are present to perform other care. So basically, every time you're in and out of a room, hey, would you like to get up and go to the restroom? That way you don't walk out of the room and 5 minutes later they need help, right? And if you just plan this as part of your day, then maybe it's less embarrassing for the person. They don't have to call you all the time, which is helpful. And it will keep them hopefully from having episodes of incontinence, because then you need to clean the bed, you need to clean up your patient, and honestly, that's more time out of your day than it is to get your patient up to urinate. There's also options like bedside commodes, where the toilet, it's a little potty, basically travel potty almost, and it's on almost what looks like a walker, and you can put it right next to the bed. And that way, if you're really worried about your person falling, or if they're having frequency and need to be out of bed often because they feel like they have to go, a bedside commode can be just right there. All right, RN considerations related to incontinence. So kind of the same deal. Maybe we're going to do a UA with culture and sensitivity just to make sure. Again, we're going to have that voiding diary. We're going to administer meds as ordered. Teaching is going to be related to whatever med somebody is on. Also, clean intermittent catheterization. If they are having residuals, meaning they are not urinating out everything that they need to, they may have to self-catheterize at home. Now at home, this is a clean procedure, not sterile, all right? But remember, our whole thing with clean is we don't want to introduce more bacteria. And so given the close proximity of the urethra to the rectal area, that's our biggest concern, because E. coli is by far our biggest concern related to UTIs. Let's see, teaching is also we're going to talk about non-pharm options, and again with that voiding diary. All right, bladder cancer. So the biggest risk factor for bladder cancer, hands down, is smoking, and then older age, followed by occupational hazards, chronic UTIs, and a long-term Foley. Diagnostics, thorough history of risk factors, right? Not only are they smoking now, but did they used to smoke? How much did they used to smoke? How long ago did they quit? You know, all those things. Urine cytology looks for abnormal cells in the urine. It's going to look for blood and tumor markers. We may do some imaging. Treatment, intravesical, can be a topical therapy for low-grade bladder cancers. It's actually like injected into the bladder. It can be intravesical, can be injected into the bladder. BCG, this is super interesting, well, to me anyway, but if you remember, BCG is that Bacilli comeddae vaccination for TB, okay? That's given in areas where TB is endemic. What they do is they put it into the bladder, intravesical, okay, and it stimulates the immune system. So the immune system then, because part of the immune system, every day our immune system grabs a cancer cell and takes it out, okay? Every day, that's happening all the time. What happens with cancers, people who are diagnosed with cancer, is the cancer manages to outrun the immune system. So by using the BCG to jumpstart the immune system, that immune system comes in, okay, and starts grabbing those cancer cells. So it's very interesting. There can also be systemic immunotherapy or targeted therapy, okay? Complications, it's cancer, and the treatments are cancer treatments. So those complications associated with disease process and what treatment we're using. All right. More RN considerations related to bladder cancer. We're also going to give meds as ordered. CBI, status post-tumor excision. CBI is continuous bladder irrigation. I put a slide about continuous bladder irrigation on the next PowerPoint. And then we need to do accurate I's and O's, because if anytime we do anything with the kidneys, the bladder, anything like that, we need to make sure that we are excreting accurately, I should say appropriately, and that we are accurately capturing that I and O. We need to make sure there's not an obstruction somewhere. That's our biggest concern. So education, expectation related to outcomes and treatments. All right, sexually transmitted infections. HPV, so human papillomavirus. So there are more than 100 known types of HPV. 40 of those types are linked to the lower genital tract. Sexually active individuals will be infected at least once with HPV in their lifetime. So that's a little scary. So out of that, HPV is very common in female individuals under 30. Approximately 75 to 80% female individuals will acquire HPV by the age of 50. It's typically temporary, okay, and has little long-term significance. So you're exposed, it goes away, no big deal. The problem is exposure to oncogenic HPV increases the risk for cervical cancer after age 30. So we worry about HPV related to cancers, okay? You can end up with cancers of the vulva, vagina, anus, and penis. So there are mild, moderate, and severe, I think I'm using the wrong words. Hold on. Low risk, intermediate, and high risk. Sorry, there we go. I knew those were the wrong words. Low risk, intermediate, and high risk. High risk HPVs cause cervical cancer. Some of the intermediates cause cervical cancer. All of the high risks cause cervical cancer. All right. The low risks are the ones that cause genital warts. So low risk cause genital warts. Low risk are also the most likely you're exposed. They get flushed from the system. Life goes on. It's interesting to note also that you can end up with cancers associated with the oral mucosa, oropharynx, tonsils, base of the tongue, all of these related to these high-risk HPVs. Risk factors: direct skin contact during vaginal, anal, or oral sexual intercourse. So risk factors are related to sexual behaviors, right? Behaviors that increase the risk of HPV include multiple sexual partners within the year and lifetime, onset of sexual intercourse at an early age. You know, the earlier you start having sex, the earlier you're likely to be exposed to this, okay? And then the more you increase your risk of being exposed to high-risk HPVs. So that's the problem there. Also, the younger you are, the riskier behaviors you may be engaging in, and that can put you at risk of exposure as well. We also worry about stuff like people on long-term immunosuppressive therapy, and that's because your body may not be able to, your immune system may not activate well enough to wipe that HPV out of your system before it's able to actually cause problems. Also, people on oral contraceptives, smoking, if you have a history of STIs, particularly herpes or chlamydia. Let's see. All right. The patho of HPV, low, intermediate, and high. Low risk, think genital warts. Intermediate can be warts or cancer. And then all of the high risk ones are associated with cancer. There is a picture. Darn it, I didn't write the page number down, but it's figure 67.1. It shows you what genital warts look like, okay? I am not putting it on my PowerPoint, but you are going to want to take a look at that, okay? Make sure you take a look at that. Signs and symptoms, you can be asymptomatic, right? Asymptomatic. Therefore, if you are engaging in risky behaviors, you should probably be screened. You may have genital warts, right? Most patients who have genital warts claim they do not have other associated symptoms, but warts can be painful and bothersome. There could be itching, burning, tenderness, and then think of the psychosocial aspects of all of this, right? Diagnostics, the pap smear for ladies, okay? It's going to be a pap smear with an HPV screen. That is the best way to screen for HPV, and that's going to diagnose any of those cancer-causing strains. So usually this is done yearly. There's testing recommendations on there. This says screening should begin at 21 years of age, because carcinoma is rare under the age of 20 years. Let's see, treatment non-cancerous, not recommended for HPV in the absence of genital warts or lesions. So if you have HPV, if you're positive but do not have genital warts, they really don't do anything for you. Genital warts is going to be about destroying the warts. They can remove those, they can use cryotherapy, they can do all of that stuff to get rid of the warts. Really, they end up being treated the same way warts anywhere else would be treated. You can use topicals or ointments. You have to think, if you're using topicals or ointments, you have to think about things like pregnancy, right? Because you're not supposed to be using those if you get pregnant. Let's see, if you have cancerous treatments, your treatment is going to vary on age, size, location, and stage of the disease, pregnancy status, probability of compliance. To be honest, you have to think about compliance with these things, because what if your person is homeless? Is this like the biggest concern in their life? It may not be. Also, cost of treatment, resource availability. So all of these things come into play. There is a vaccination for HPV. You're going to want to know like the recommendations related to that vaccine. This is a safety alert about genital warts and pregnancy. This is slide 34. Safe administration of the creams, gels, and ointments used to treat warts has not been established in patients who are pregnant and therefore should be avoided. If the pelvic outlet is obstructed by genital warts, a cesarean section may be indicated. This talks about the vaccine. So this is little, I need to read it. Let's see, recommendations. So there's 3 doses between the ages of 15 and 16. Let's start over here. 3 doses between the ages of 15 and 26. There is a 2-dose vaccination that can be given between 9 and 14. The target age is 11 to 12 years old. Basically, we want to give this HPV vaccine, we want to start this before kids become sexually active. All right, because once you become sexually active, you have likely been exposed to HPV. So initiate the vaccine between 11 to 12 years old. Now, they do say that you can give the vaccine as early as 9 years old, which is so sad because this is children who we consider to be at particular risk. So whether this is sexual abuse, whatever the circumstances may be, you can give that vaccine as early as 9 years old, but that target age is 11 to 12 years old. You can also now give it between 27 to 45 years old. Now, if again, the whole idea is to take that vaccine before you are sexually active, but you can still get that vaccine between 27 to 45 years old. So take a look at this slide. It's slide 35. So it is said to, the vaccine is said to reduce the incidence of cancer and genital warts by 90%. So, I mean, that's pretty significant. All right, this is a slide in here. Oh, here we go. I want you to read the safety alert on page 1645, and I want you to look at the picture of the genital warts on page 1645. Again, I'm not posting that picture. You guys have to look that up on your own. This is RN considerations related to HPV. Our assessment is going to be pain, presence of genital warts, actions, administer meds as ordered, education, prevention, vaccination, med administration, notify physician if worsening pain and or vaginal discharge. You're also going to want to talk to them about partner exposure, right? And think about the psychosocial aspects of all of this. We're going to want to talk about like healthy practices, routine exams and primary care. If they start the HPV vaccine, right, you have to get, there's several doses of it, so get all the doses. All right, moving on to syphilis. Syphilis, I really like syphilis. It's a spirochete. I'm sure I've put a picture in here of it because it's super fun. Syphilis, complex chronic infection that has the ability to acutely or chronically infect every organ of the body. Every organ, okay? It's classified into 4 stages: primary, secondary, latent, which is early and late, and tertiary. Tertiary stage is also classified as cardiovascular and gummatous. Neurosyphilis, which means it has traveled to the CNS, can be classified as tertiary, but can actually be present at any stage. Syphilis can get into your central nervous system. Back in the day, before we knew a cure for syphilis, which, by the way, plain old penicillin, but people would go crazy. They would get, syphilis would invade the CNS and they would go nuts. That is what, and then once, usually by the time it invades the CNS and you are having CNS signs and symptoms, you're gonna die. You're done for. Syphilis is an ulcerative, so it causes holes, okay? Genital disease caused by the anaerobic spirochete Treponema pallidum. It's a bacteria. It invades the mucous membranes and then goes systemic because it enters the blood and the lymph system. CNS can be invaded early in the disease. Incubation is about 3 weeks. You do not have to memorize all of these stages. Just know, like primary syphilis, it initially manifests as a canker. A canker is a painless hard lesion that can develop into a painless open lesion located at the site of exposure. So this can be like the vulva, vagina, anus, penis, rectum, lips, oral pharynx. Wherever you came in contact is where you're going to get this canker, and then it turns into this ulcerative hole, okay? Cankers, they're going to last about 3 to 6 weeks with or without treatment. You may get lymph node swelling. That's going to happen like during the canker stage or as part of secondary syphilis. If you do not receive treatment with primary syphilis, the infection travels systematically and it progresses on to secondary. So secondary syphilis, you get this rash and or mucous membrane lesions. The rash in particular is super weird because you get it on like your palms, the soles of your feet, it's buttocks, upper thighs, right? It's just super weird. And then you get hidden syphilis, latent syphilis. So this develops after secondary symptoms. It lasts it's typically like 1 year after the initial exposure, okay? And then in the latent period, actually risk of sexual transmission is low. So at this point, so you've gotten cankers, they've opened up into sores, then you end up with this weirdo rash on these weirdo places, and now you go into this latent period, okay, about a year later. So at this point, you can spontaneously resolve the infection, so your immune system wins. You can remain latent, or you can progress to late or tertiary syphilis, all right? There's 3 types of tertiary syphilis. There's neurosyphilis, cardiovascular, and gumatitis. Gumatitis is skin and subcutaneous tissues, all right? Neurosyphilis, we talked about, you know, it can be asymptomatic, but ultimately people end up going crazy with this if it progresses to this part. It's really crazy. Cardiovascular and gumatitis, it just causes a lot of damage, right? And then because it ends up kind of being widespread, it just causes damage and you die from this. Now the thing is, we treat this with penicillin, okay? So because penicillin is so widespread and cheap these days, luckily we don't see syphilis progressing onto that late stage anymore. But think about your homeless population who may not go to a clinic, right? They may not drop into the ED. They may just ignore these signs and symptoms. And then it can progress and ultimately, like I said, you're gonna die. Diagnosis, blood and microscopic testing. Again, treatment, good old-fashioned penicillin. Here's a really nice picture of your little spirochete. Look at him, he's all curly. He almost looks like some fun spaghetti. There is spaghetti that's shaped like this. I don't know what it's called though. I should bring it in. We can play with it. All right, treatment, penicillin. Now, a lot of people are allergic to penicillin, right? So if you're allergic to penicillin, we're going to use doxycycline. Okay, that's our first line alternative. Now the problem is you cannot take doxy if you're pregnant. So one of the weirdo things that they do is called desensitization. If you are pregnant and have syphilis and you're allergic to penicillin, they will actually put you in the hospital and give you small doses of penicillin while you are being monitored to help get rid of the syphilis, all right? And this is because you can't take doxy, but penicillin is so much more effective, honestly, at treating syphilis than doxy. And they need to treat you for the syphilis. They need to treat you because otherwise it's going to progress. So that is called desensitization, all right? They're going to give you Benadryl. You're going to be on a 1-to-1. We're going to be in there with you the whole time. And that's for pregnant ladies allergic to penicillin. RN management of syphilis, this slide 40, also has a really nice picture of syphilis. So the signs and symptoms of syphilis, they vary by stage of the disease, right? So we are going to look for presence of those cankers. We're going to look for presence of the rash, neurostatus, serology, right? We're going to look at the bacterial load, actions, administer penicillin as ordered, doxy if you're allergic to penicillin, and then desensitization treatment if you're pregnant. Teaching, seeking, and maintaining treatment. And then talking safe sex practices, right? Also, the book always talks about reporting these diagnoses to partners, but most of these are reportable infections, which means that the health department is going to get involved. They are going to ask you for names of your partners, and then the health department is going to reach out to your partners. Okay, so yes, we want you to alert your partners, but also the health department is going to interview you and just get the names of those people and contact information if you have it. All right, moving on to genital herpes. Genital herpes, not as cute as that spirochete, not as cute. Genital herpes, highly contagious infection caused by herpes simplex virus. Entry can occur through minute breaks, such as scratch or abrasion through uninfected skin. The herpes simplex virus travels from the site of infection, skin or mucous membrane, via the lymphatic, blood, or ascending nerves to the sacral ganglion cells and remains latent until it becomes reactivated and travels down many different sensory nerve fibers. Herpes antibodies develop after the initial infection. Generally, genital herpes is transmitted by direct skin-to-skin contact during the prodromal stage of infection. This is the onset of infection. So infection can occur through oral to oral, oral to genital, genital to genital, or anal contact. Transmission can also occur during childbirth. Virus may shed from persons with or without symptoms. That's one of those things to remember. You do not have, herpes is a blister, right? It's a blister, it pops, it turns into a sore, it has that infectious fluid inside, and obviously you can transmit it via that popped blister, but you can also spread it while you have no signs or symptoms, right? And there's herpes simplex 1, which is what we normally associate with like cold sores, and herpes simplex 2, which is what is normally associated with genital herpes. I remember that because it's genital herpes, and I always think it takes 2 to tango. Okay, so herpes simplex 2 is what we normally associate with genital. Herpes simplex 1 is on your lips. So let's see. Outbreaks can occur episodically. Primary or initial outbreak is usually your most severe outbreak, and then your subsidiary outbreaks tend to be a little bit lesser. You're going to get, it forms as a blister, it ruptures, and then you end up with an ulcer. The ulcer can last 2 to 4 weeks if untreated. Don't forget, herpes simplex virus, it's a virus, it travels the CNS. So it can lay dormant in the sacral area in the CNS, and then it just rears its ugly head when it wants to, usually related to stressors or triggers of some sort. Triggers to these outbreaks can be physical factors like immunosuppression, UV radiation, fatigue, even the menstrual cycle. And then, of course, we always have our psychological factors, right? Frequency, duration, they're all dependent from patient to patient. Symptoms tend to be more severe in females. Outbreaks or episodes tend to decrease over time. Again, do not forget the psychosocial aspects related to this, right? I mean, especially if you're younger, you're dating, you're out in the world, right? This could be horrible. Diagnosis begins clinically through visual inspection of the oral, genital, and anal areas. They can do a cell culture and PCR testing. And those are preferred preferred methods, but really an HSV ulcer or lesion is pretty stereotypical. It looks like what it looks like. Medication therapy, we can use antivirals. One of the things with these antivirals, you know, I get cold sores, right? And you can feel the cold sore coming on. So one of the things with this therapy is you can start treatment during the prodromal stage, which is where you feel like that tingling or that itching coming on, okay? And that is recommended. People can get, on top of the blisters and everything, people can get fever. They may be tired, headache, dysuria, lymphadenopathy, you know, like your lymph nodes may be tender. All of that stuff can happen, especially related to genital HSV2 infections. Suppressive therapy. Remember, we're not getting rid of this. This is now in the CNS. It is hanging out with your chickenpox virus, right? So it's suppressive therapy. We're keeping this virus at bay. We're not curing it. So your suppressive therapy requires regular daily dosing. It can reduce your incidence of outbreaks easily by 70–80%, and it also reduces transmission. So we're going to use suppressive therapy, and then you're going to use therapy during outbreaks to help reduce how long that takes. I just realized I put a picture of a spirochete on a genital herpes slide. Sad. That's how much I love spirochetes. I'm not even paying attention. This is not a picture of genital herpes. It is not this cute. RN considerations related to genital herpes. So assessments, we're going to look for the blisters in genitals and buttocks areas. Actions, administer meds as ordered, maybe support groups because of the psychosocial aspects of this, right? Counseling, education, we're going to talk transmission. We're going to start treatment during the prodromal phase. Abstinence during symptomatic outbreaks, okay? While you're symptomatic, you have a much greater risk of transmission to your partner, okay? Warm salt baths for outbreaks, ice, loose fitting clothing. You know, these are blisters and they turn into a sore. So anything you can do to help mitigate the pain related to that. All right, moving on to chlamydia. Chlamydia is the most common sexually transmitted bacterial infection. This is a bacteria. It is a urogenital infection that primarily infects the urethra and cervix. It is transmitted through vaginal, anal, or oral sex via bodily secretions. So transmission may occur during childbirth and lead to conditions such as conjunctivitis, pharyngitis, and pneumonia. Incubation period 5 to 14 days. However, you can be asymptomatic and they're not exactly sure like how long you can carry chlamydia and remain asymptomatic, or you know, you're asymptomatic so you're just passing it along because you're not even aware that you have it. Most individuals who contract chlamydia have no symptoms. There you go. Only 5 to 30% of females and 10% of males will develop symptoms. So it's out there. Diagnosis of chlamydia is made through a swab specimen from the vagina, cervix, penis, urethra, rectum, or other involved orifice. To obtain a specimen from the male patient, you ready for this? The swab is placed in the urethral meatus about 2 to 3 centimeters. They put the swab up the PP. How's that for you? Many reports describe the coexistence of chlamydia with gonorrhea. A lot of times with chlamydia or a gonorrhea diagnosis, they will automatically treat you for the other because these two love to coexist. All right, so they will either screen you for both if you're if you're diagnosed with one, they'll screen you for the other, or they just will treat you for both. The biggest thing with chlamydia is you should be re-screened in 3 months. This is true for gonorrhea as well. We do re-screening in 3 months because there is a high risk of reinfection. So medication therapy, we're going to do doxy or azithromycin for non-pregnant people. Remember, our pregnant individuals cannot take doxycycline. We are also going doxy or azithromycin for HIV people too. That is fine. With pregnant people, we go to the azithromycin. All right. They will use amoxicillin as well. Okay. Let's see, complications. Left untreated, it can travel in females to the uterus and the fallopian tubes and cause a condition called PID, pelvic inflammatory disorder. So pelvic inflammatory disorder is a disorder related to STIs. Okay, it's a consequence of STIs. We will talk about that also. In males, chlamydia infection can spread as well. It can go to the epididymis, causing inflammation. It can also infect the prostate. So basically, this will travel on you is really the problem. So it can cause a lot of other pain and reactions. It can end up causing arthritis, which is super weird. It doesn't happen that often, but who wants to have arthritis because of chlamydia, you know? You can also end up with inflammation in the urinary genital tract, conjunctivitis, and inflammation of the mucous membrane lining the eyes. We actually treat babies at birth with the little azithromycin is the cream that they just put in babies' eyes like automatically when they're born, and that is for chlamydia and gonorrhea. Slide 44. So this is expedited partner therapy. When you are either diagnosed with chlamydia or gonorrhea, all right, what they will do is instead of testing your partner and making them come in, and maybe they don't come in, or maybe you don't want to tell your partner, or whatever the case may be, they just automatically treat your partner, because the risk of transmission is so likely, they just treat your partner. Okay. This is another one. These are also reportable infections. So they're going to ask you about partners. Health department gets involved. They're going to ask you who your partners are. They are going to contact your partners, and they are going to recommend treatment at that point. Slide 45 has clinical signs and symptoms in females versus males. Look at the big old long list for females versus males. Notice with chlamydia, you can have rectal infection that may occur in females and males. Okay, you're going to have discharge, anal itching, soreness, bleeding, and painful bowel movements. All right, so not good. That could be, and imagine you're a young person. Are you going to want to talk about this? Probably not, right? It's going to be embarrassing. So just take a look at that list. That was slide 45. All right, RN considerations related to chlamydia. So signs and symptoms of UTI is what you're gonna kind of see. So dysuria, painful intercourse, unusual bleeding or discharge. Actions, meds as ordered. Education, safe sex, report infection to sexual partners. Health department's going to do that for you. And also we want to know if your signs or symptoms worsen, because that can mean worsening infection, right? Maybe we need to redose you. Don't forget to be retested in 3 months, okay? Repeat infection, very, very likely with this stuff. All right, moving on to gonorrhea. There we go, gonorrhea. Diagnosis, they may do a NAT, they may do a culture of some sort. This too is transmitted genital to genital, oral to genital, anal to genital, perinatal transmission possible. Diagnosis, NAT assay, let's see, or culture, right? We could do a culture. Treatment, third generation extended spectrum cephalosporins. So this is your ceftriaxone preferred first choice. It has the highest cure rate. Ceftriaxone can be administered IM or IV. If we're thinking cephalosporin allergy, then we would go to IM gentamicin, and that's a single dose, which, that's not a bad idea. And then you do azithromycin, PO. Also, if they have not ruled out chlamydia, okay, they're going to test for that too, because chlamydia and gonorrhea like to hang out. They're going to put you on doxy for 7 days along with your gonorrhea treatment. Complications, PID, abscesses, infertility, in male patients, epididymitis. Let's see. You can end up with systemic complications like arthritis. With gonorrhea, you can also get skin lesions, and it's rare, but gonorrhea can lead to endocarditis and meningitis. So there's some pretty decent complications related to that, right? RN considerations, dysuria, rectal pain, vaginal bleeding, or some sort of discharge, right? Actions, administer those antibiotics. Education, safe sex, report infection to partners. Again, though, health department's going to do that, and get retested in 3 months. Pelvic inflammatory disease. So pelvic inflammatory disease is not really a disease. It is caused by other STIs, or by STIs. I shouldn't say other STIs because it's not an STI. It is a consequence of STIs. All right. Let's see. So you can see it related to chlamydia, gonorrhea, let's see, patho, acute infection that originates from the vagina or cervix and ascends to the upper genital tract, infecting the uterus, fallopian tubes, and ovaries. PID is a polymicrobial infection caused by an STI, such as chlamydia or gonorrhea, or by other pathogenic microorganisms that compromise the normal vaginal flora. So basically, you get an infection, it travels, it ends up causing this inflammatory state. So clinical manifestations, lower abdominal pain, uterine tenderness, cervical motion tenderness. Diagnosis, it's hard to diagnose because we're not going to swab for it. It's just symptoms, okay? So, and clinical manifestations related to PID can have other causes. So we need to rule out those other causes, and then we're going to go with a diagnosis of PID. They're going to look to see if you have an STI like chlamydia or gonorrhea. You are probably going to present with our typical signs and symptoms of infection, like temperature, not feeling good. You can have purulent discharge. You may have an abundance of WBCs in the vaginal fluid, our ESR, our CRP, all that stuff. They can use like MRI, potentially, Doppler studies, just looking for inflammation. Treatment is going to be related to what infection they think you have. All right. Let's see. They may actually hospitalize you related to this if you do not respond well or tolerate PO antibiotics. They may want you on IV. If you're pregnant, if you have severe illness, if you have a differential diagnosis like tubo-ovarian abscess or appendicitis, or if you have an ectopic pregnancy. This just talks about, we have in here treatment for hospitalized patients. You don't need to memorize that. Just know that complications of PID can actually end up with infertility, right? So it can be an extreme complication. This slide 50, page 1661, looks at this is a picture looking at the effects of PID. So basically this is just looking at the inflammation that it causes. And then when you get an infection, you end up with scar tissue, right? And you can end up with inflammation related to that scar tissue. So obstruction is a potential related to this. And obviously that would be very painful and require surgical intervention. So here are our RN considerations related to PID. We're assessment, pain, unusual vaginal bleeding or discharge, sexual practices, previous STI or PID, actions, meds as ordered, right? And then education, safe sex practices, and then call provider if there are worsening signs or symptoms. Because again, this is a bacterial infection and bacteria loves to travel. So you of course always run the risk of something going systemic and then resulting in sepsis when we are talking bacterias, because they just like to do that. All right, so this concludes this one. Do not forget that there is a second slideshow, 7B. Thank you.